Hello everybody, my name is Brady Wong and I'll be speaking to you about imaging of the brachial plexus with emphasis on MRI. A little bit of a philosophical question. Who in your practice reads brachial plexus MRI? Is it the neuroradiologist? Perhaps it's the musculoskeletal radiologist or the chest person or even the vascular interventional radiology person. Maybe all of the above, as the brachial plexus really represents a crossroads of multiple areas of discipline, including musculoskeletal, vascular, and neuroradiology. And in some cases, it might be none of the above. You may encounter a brachial plexus study on your work list and may want to run away in the opposite direction, but hopefully in the next hour, you'll learn enough about the brachial plexus so that you'll be able to interpret these studies. Why image the brachial plexus? Well, the vast majority of cases that we see, at least at UCSD, is related to trauma. This could be penetrating injuries or potentially stretch injuries, most commonly in the setting of motor vehicle accidents. It may be performed in the setting of unclear clinical presentations. These patients may present with symptoms similar to cervical radiculopathy or cervical canal stenosis, or perhaps an upper extremity peripheral neuropathy, or in some cases something in between, and that something in between is the brachial plexus. And finally, we'll touch on the role of brachial plexus imaging in the diagnosis and management of thoracic outlet syndrome. If you look at the ACR accreditation manual, you have to submit your images for accreditation for your MR magnets. You'll notice that there's no specific module for brachial plexus imaging. So that doesn't give much in the way of guidance to properly image the brachial plexus. There are some references in the literature. Here's a good one from AJNR in 2013 that gives some guidelines on how to optimally image the brachial plexus. This was offered actually on a Siemens magnet. We use a lot of GE hardware, so obviously this is going to be dependent on your vendor and software versions. But suffice it to say, it's important that you have a combination of really good high-resolution T1 or anatomic images and T2 fat-suppressed or some sort of fluid-sensitive sequence to image the nerves themselves. And at UCSD, we use a combination of large field of view and small field of view sequences. Obviously, large field of view to just kind of get a lay of the land, and small field of view to get a more detailed look at individual brachial plexus elements. And the fluid-sensitive sequences help you identify pathology. And we actually use some isotropic sequences or 3D fast-spin echo sequences so that we can reconstruct in other planes. Certainly, if you're evaluating thoracic outlet syndrome, we do use gadolinium contrast intravenously. It has a really great signal-to-noise profile when looking at the vasculature, and particularly for TOS, we do dynamic maneuvers with the arms down as well as the arms up. And in some cases, we actually do some head turns to the left and right if the clinician requests. So here's just a sample of a brachial plexus done on our magnets. This is large field of view T1 and T2 fat suppressed sequences. You can see kind of in the mid portion of this clip, you can see the brachial plexus nerves emerging from the spine. And to the right of this, we have our isotropic sequence. This is a cube sequence. It's called different on different vendors. But this is your 3D isotropic sequence that allows you to reconstruct in other planes. Just below that is such a reconstruction, an oblique axial reconstruction where you can see kind of the nerves laid out in their long axis. And then to the left of that, we have our small field of view T1 and fluid-sensitive sequences to evaluate the nerves. And this is kind of where I like to spend most of the time looking at the nerve anatomy. This next image stack, we just have the T1 and T2 fat-suppressed small field of view images, again, just to get better detail of the nerves as they come out of the neck. And finally, our post-contrast sequences, we have arms down in the middle and arms up on the right to get a sense of if there's any vascular narrowing in that costoclavicular space when the patient raises their arms. And certainly if you want, you can throw in a dynamic sequence at the time of injection to look at vascular kinetics. It's important to understand the anatomy of the brachial plexus. If you remember back to your medical school gross anatomy days, the brachial plexus begins proximally at the level of the neck with 5 distinct cervical nerve roots labeled C5, 6, 7, 8, and T1. They coalesce to form 3 trunks, each dividing into anterior and posterior divisions, so giving rise to 6 divisions, which will then recombine to form 3 cords, and then will subsequently branch and recombine again to form the 5 terminal branches. The surgeons tend to think of the brachial plexus more as its relationship to the clavicle. Above the clavicle or supraclavicular portion of the brachial plexus, you'll have your roots and trunks. At the level of the midclavicle, just behind, you'll have those 6 divisions. And then infraclavicular or below the clavicle, you'll have the cords and the terminal branches. Even though it looks nicely shown in those anatomic depictions in the textbooks, this is what it looks like more in real life. You can often identify the 5 nerve roots as they emerge from the neck, but they rapidly coalesce into their trunks and the remainder of the brachial plexus as this tangle of nerves. So it's really important to have really good high-resolution imaging so that you can tease apart these various components of the brachial plexus. So again, like I said, I like to look at the sagittal images most for identifying the individual components of those nerves. So I've labeled the 5 nerve roots. Using the first rib as your anatomic landmark is important. That helps you separate C8 from the T1 nerve root. And just be careful if you have a cervical rib that can throw off your count. So make sure that you look at the rest of the cervical spine or look at some x-rays. So as we move more peripherally, we can see the individual nerve roots. These are going to coalesce to form the trunks, upper, middle, and lower trunks. So C5 and C6 forming the upper trunk, C7 by itself forming the middle trunk, and C8 and T1 forming the lower trunk. You'll notice in this anatomic space, this is referred to as the interscalene triangle. So in front, we can identify the anterior scalene behind the middle scalene. And also notice what lives in this interscalene triangle is the subclavian artery. But outside this interscalene triangle, in front of the anterior scalene, is the subclavian vein. As we move more peripherally, we move into the second anatomic space, which is the costoclavicular space. And we can identify those 6 divisions. So those upper, middle, and lower trunks have each divided anterior and posterior divisions to form 6 nerve groups. We can see the relationship of the subclavian artery to those divisions. And as we move more distally, we encounter the cords, of which there are 3, kind of anterior superior, we have the lateral cord, more posterior superior, we have the posterior cord, and sort of straight posterior, we have the medial cord. And people like to liken the appearance of the cords as a stack of cannonballs, so look for this triangular configuration of nerve bundles adjacent to the subclavian artery. And it can also be confusing to determine which cord you're looking at. So I always like to think of the Vitruvian Man that Leonardo da Vinci depicted, whereas when you stand in the anatomic position, the thumb points up or towards the sky. So that's the lateral part of the arm, whereas the small finger or pinky part is the medial part of the arm. So if you can think of the Vitruvian Man standing with his arms outstretched, lateral is more superior and medial is more inferior. And as we move more peripherally, we'll encounter the last or third anatomic space. This is the retropectoral, or sometimes referred to as the pectoralis minor space, comprised of the terminal brachial plexus branches. And you can see right here behind the pectoralis minor muscle, those 5 branches. So what do we look for in brachial plexus imaging? Like I said, most of the time we're imaging it in terms of trauma, but you may also be asked to evaluate in terms of compressive syndromes. The prototype is thoracic outlet syndromes. We also may encounter infections, certain neoplasms or masses. And finally, kind of a hodgepodge of neuropathies or neuritis, which can be congenital or acquired. And one thing that can help you hone or narrow down your differential diagnosis is look to see if this is a unilateral versus bilateral process, or whether it's focal versus diffuse. And having a good clinical history is of paramount importance. And in some cases, actually having electromyographic data, EMG or nerve conduction studies to help kind of guide your search pattern. Now, it's important to recognize the proximal type of brachial plexus injuries, those close to the neck. And these come in two forms. These are the preganglionic injuries and the postganglionic injuries. And basically, the anatomic boundary between those two is the dorsal root ganglion itself, hence the name. So injuries central to the dorsal root ganglion are designated preganglionic injuries, and lateral to it will be the postganglionic injuries. And these can come in the form of preganglionic ruptures or stretches, as well as postganglionic stretches and ruptures. And really defining the anatomic levels of these is really important to help guide treatment, whether it's surgical or conservative. Now with preganglionic injuries, as you can imagine, these are very difficult to treat surgically, and these may require nerve grafting procedures from other intact nerves to help supply those denervated muscles. Whereas the postganglionic injuries could be treated with conservative management if they're just stretch injuries, or potentially with nerve grafting procedures, given that they could potentially be accessible to surgical exploration. As far as preganglionic injuries go, it's important to understand the anatomy here. Here you can see the nerve root as it emerges from the spinal canal. It is encased by the nerve root sheath. And you can have various grades of injuries where the nerve root sheath itself is injured, but the nerve root itself is intact or stretched. And then finally, in more severe cases, you have both ruptures of the sheath as well as the nerve root itself, obviously being a more severe injury. And when you have tears of the sheath, this can result in the appearance of pseudomeningoceles. And these are characterized by these kind of outpouchings of CSF fluid extending towards the neural foramen. And what you can see as an indirect sign of these is you may see displacement of the spinal cord to the contralateral side. In fact, in this case, you can actually see the nerve rootlets emerging from the contralateral side, these ones being intact and these ones being disrupted. So CT myelography is a fantastic way to image the nerve rootlets. Obviously requires an intrathecal injection of contrast, but this case nicely showing multiple pseudomeningoceles with these outpouchings of contrast extending along the left neural foramina. Here again, you can see it on the conventional myelographic image. And of course, the great thing about CT is a high resolution and that you can reconstruct it in other imaging planes. So for instance, in this case, we can see that there's 3 levels involved with pseudomeningoceles at the level of the C7, C8, and T1 nerve roots. So these all suggesting the presence of a preganglionic injury. And if you can kind of hallucinate, you can almost see the nerve rootlets on the contralateral side being intact compared to the other side where they are disrupted. Here's a case of an unfortunate patient who had a near amputation of the right upper extremity 10 days earlier. And as you can see, this patient actually already had a vascular procedure. You can see that there's a vascular graft extending from the axilla to the carotid artery. So that was a carotid artery to axillary bypass. And if you look at the kind of retropectoral and costoclavicular space, you can see that there is this soft tissue hematoma with these retracted nerve elements derived from multiple nerve root avulsions. So basically the torn brachial plexus slingshotted from the neck towards the retropectoral space. So you can almost see this kind of bag of worms appearance of nerve elements retracted towards the axilla. Here's the corresponding sagittal image, and hopefully you can appreciate that there are multiple levels of pseudomeningoceles. Remember, try to identify your first rib that'll help you distinguish the C8 from T1 nerve root. So we can say that for certain we have involvement of the C8 and T1 nerve roots in this case. And then we can kind of see this bag of worms appearance of the torn, retracted brachial plexus elements. So for all intents and purposes, this patient had a complete avulsion of their brachial plexus. So be careful. These traumatic avulsions can only involve the root sleeve without actually involving the root itself. So just because you see a meningocele doesn't mean that you have a rootlet injury. It is a sign of a preganglionic lesion, but it's not certainly pathognomonic. So it should really raise your suspicion. And if you see these findings, I'd urge that you either perform a CT myelogram, as we saw in that case, or some sort of high-resolution cervical spine MRI with a rootlet protocol to really see if you can identify those nerve rootlets within the spinal canal to help make the diagnosis of a preganglionic rootlet avulsion. Now here's just an example of a patient 2 weeks out from a brachial plexus injury, and this is where high-resolution fluid-sensitive sequences through the brachial plexus can help you make the diagnosis. And in this case, you can see that there are thickened bulbous torn ends of the left brachial plexus. And of course, using the right as a contralateral internal reference can be helpful. So you can see multiple levels of root avulsion here in this patient post-injury. And you can also see that there's often edema within the neck musculature. If you remember, those scalene muscles all also innervated by the cervical nerve roots as well. Now here's just another example of a patient with nerve root avulsions using CT myelography. You can see in the lower nerve root segments a couple small pseudomeningoceles. You can actually see the exiting nerve rootlets on the contralateral unaffected side. As we move further down, again, we can see nerve rootlets, and then on the other side, the affected side, we don't really see normal nerve rootlets accompanied by a pseudomeningocele. And of course, with CT myelography, we can reconstruct in other planes. Here, the coronal plane showing this injury, and we can see, again, the pseudomeningocele. You can sort of hallucinate the nerve rootlets as they come out of the spinal cord. And on the other side, we don't really see any nerve rootlets, so really suspicious for a preganglionic rootlet avulsion. And here's the same patient, their brachial plexus MRI. Again, we can observe the presence of pseudomeningoceles related to the preganglionic injury. And we can actually see the difference in side-to-side appearance of the affected brachial plexus, where we can see these areas of nodular thickening related to retraction of those avulsed nerve rootlets from the neck. And really, I think in combination with the CT myelogram, this helps to cinch the diagnosis. And the reason why CT myelogram was used in this case was the presence of this metal artifact related to this patient already having an ACDF. So it was thought that a rootlet protocol MRI may not have been optimal to visualize the rootlets within the spinal canal. Certainly, when you see this high energy trauma, you want to be on the lookout for associated vascular injury. You can see that this patient does have a acute cutoff sign of their distal subclavian/axillary artery, which actually reconstitutes distally in this patient with this fractured dislocation of the proximal humerus. So be on the lookout of that. You want to consider doing dedicated vascular imaging, whether it's CT angiography or even conventional angiography. As far as incomplete injuries go, there are two forms that can occur. The first type we'll talk about involves the upper brachial plexus, the second involving the lower brachial plexus. These are typically going to be seen in these kind of neck stretch injuries where somebody kind of falls onto their shoulder, resulting in stretching of the upper components of the brachial plexus. So that's primarily going to be the C5 and C6 nerve roots. And the motor deficits that are characteristic of this injury include loss of flexion, abduction, and lateral rotation of the shoulder, and often loss of sensation of the lateral aspect of the arm. Now, this is also commonly seen, unfortunately, in birth trauma, referred to as Erb-Duchenne palsy. When the arm is pulled during delivery, the preferential involvement of the C5 and C6 nerve roots affects the suprascapular, musculocutaneous, and axillary nerve and results in this classic waiter's tip position with the arms internally rotated and the wrists flexed. And unfortunately, there's a bunch of lawyer websites on this topic because this is a very litigious area as it relates to obstetrics. And patients who have Erb-Duchenne palsy can develop a glenoid hypoplasia, which is a dysplastic appearance where the glenoid is retroverted and hypoplastic in appearance, and often accompanied by the surrounding muscle atrophy, as can be seen in this case. And again, the characteristic appearance of this is internal rotation of the shoulder, extension of the elbow, and flexion of the wrist. And again, you can see this is accompanied by glenoid hypoplasia. You can see this increased retroversion of the glenoid and sort of overgrowth of the cartilage and labrum of the posterior aspect of the glenoid. The other form of incomplete injury that can occur is along the more inferior parts of the brachial plexus. This too, the result of a stretch injury, but along more the axillary portions of that brachial plexus. So as you can imagine, it's going to affect the lower portions, in particular the C8 and T1 nerve roots. This will result in generalized loss of wrist and finger movement and loss of sensation at the medial aspect of the arm, as opposed to the upper brachial plexus injuries that we saw earlier. And this too can also be seen in the context of birth trauma with excessive traction on the arm. And this results in the classic appearance of what's been termed Klumpke's palsy, which is a sort of claw hand appearance related to interosseous and lumbrical denervation. As we move more peripherally into the second anatomic space, which is the costoclavicular space, this is where we may encounter hypertrophic non-unions or malunions of clavicle fractures, resulting in impingement of the brachial plexus in that costoclavicular space. You can see deep to the clavicle, there is a muscle here referred to as the subclavius muscle, and just beneath that muscle are the brachial plexus nerve elements. Now that muscle does help to protect the nerves from a clavicle fracture, but as you can imagine, there's not a lot of space between this clavicle and the first rib, and hence this is why this area can be prone to impingement. As we start to move even more peripherally, we'll encounter some of the peripheral branches of the brachial plexus. Now, a classic palsy that can occur around the shoulder is that of suprascapular nerve entrapment. Typically, that's going to be seen in relation to paralabral cysts, most commonly at the spinal glenoid and suprascapular notches. Here's an example of a suprascapular notch cyst resulting in denervation edema of both the supraspinatus and infraspinatus muscles. You can notice how the rest of the rotator cuff muscles are spared. So this is the classic distribution of suprascapular nerve denervation. There are two nerves that arise from trunks. The first, more important, is that suprascapular nerve, and the second and less important is the subclavius nerve to that subclavius muscle I just told you about. Now, additional peripheral nerve injuries may come in the form of axillary nerve injuries. Here's just an example of one. Now, this is a patient who suffered an anterior glenohumeral joint dislocation. You can see the post-reduction images showing the classic Hill-Sachs lesion at the posterolateral aspect of the humeral head. So this is the course of the axillary nerve. In the axilla, it's a branch of the posterior cord of the brachial plexus, the other branch being the radial nerve continuing on into the upper arm. And as you know, the axillary nerve travels through the quadrilateral space, bounded superiorly by the teres minor muscle, inferiorly by the teres major muscle, medially by the long head triceps muscle and its tendon, and laterally by the humerus. And we try to look for quadrilateral space masses in the context of teres minor atrophy. And as you know, that may be related to paralabral cysts, osteophytes, or sometimes fibrous bands that can't be seen well MRI. But certainly in the cases of anterior glenohumeral joint dislocation, what happens is the humeral head dislocates anteriorly and itself becomes a space-occupying mass, resulting in stretching of that axillary nerve as it traverses the quadrilateral space. So here is the subsequent MRI in that same patient who suffered the glenohumeral dislocation. And you can see the characteristic denervation edema, this time involving the teres minor and the deltoid muscle. You can see that there is relative preservation of the suprascapular nerve muscles in this case. So here's the corresponding image stacks in this patient, the coronal fluid sensitive sequence. We can see the telltale signs of the glenohumeral dislocation with the Hill-Sachs lesion and the associated tearing of the anterior-inferior labral ligamentous complex. You can also see the accompanying denervation edema of the deltoid and the teres minor. But as you look through this image stack and you go back to your brachial plexus anatomy, behind that subclavian artery, you can see the posterior cord of the brachial plexus, and as we move more peripherally, it's going to give rise to that axillary nerve branch here, and you can see that that axillary nerve branch is hyperintense and thickened, reflecting a stretch injury, and this is why we have the denervation pattern within the muscles. And likewise, on the sagittal oblique images, we can see the axillary nerve as it travels within the quadrilateral space here. Again, you can see that is enlarged here as it arises from the posterior cord of the brachial plexus. Here's another example of a patient who suffered an anterior glenohumeral dislocation. This patient had a higher grade peripheral nerve injury. They actually didn't recover. So you can actually see the brachial plexus in its entirety. Again, try to identify that first rib, which is right here. So underneath it is the T1 nerve root, above it C8, and then 7, 6, and 5. So as we follow these nerve roots, we can see the formation of the trunks, upper, middle, lower trunk, subsequently the divisions, and then finally as we move more peripherally, we can find the cords. Remember, lateral, posterior, and medial, and this posterior cord is already looking a little bit brighter than the other cords. As we move more peripherally, indeed, it does look brighter as we move into the axilla. And so for some reason or another, this patient actually had a more central injury involving the posterior cord rather than the axillary nerve itself. But you can see the associated denervation edema of the deltoid muscle compared to the other muscles. So this patient actually had loss of triceps extension as well, which is supplied by the radial nerve, also a branch of that posterior cord. And this patient required a nerve transfer to regain function of both the deltoid and the extensors of the elbow. Now, there is a grading system for grading nerve injuries. This is more of a surgical grading system, but there have been papers out there trying to correlate morphology of the nerve findings on MRI with those of surgical findings. But this is the Sunderland classification, graded 1 through 6. Usually 1 through 3 are the most mild forms and are generally treated conservatively. The grade 3 form may be treated with neurolysis. But if you have higher grade injuries, anywhere from grade 4 through 6, those are generally treated surgically. Now, the grade 4 injury is kind of interesting in of itself because what happens is the epineural nerve sheath, which is that most peripheral connective tissue, is the only part of the nerve that's intact, whereas everything inside is completely disrupted. And so what you'll get is what's called a neuroma in continuity, which on imaging may look like a thickened but continuous nerve. For all intents and purposes, it's a non-functional nerve because all the elements within it have been disrupted. Now, it has been shown in the literature that nerves can recover at a rate of about 1 millimeter per day. So in these mild forms, that's why these nerves can potentially recover. So this is more just information for you when you're looking at these studies, that there is a grading system out there. Now we'll move on to talk about brachial plexus compression. There are several sites of compression that can occur. This can again be in any one of these three spaces, the interscalene triangle, the costoclavicular space, or the subpectoral space. But more commonly, you're going to see this in the costoclavicular space, so that space between the clavicle and the first rib. And this gives rise to the discussion of thoracic outlet syndrome. This was first described by Dr. Adson, for which the famous Adson maneuver is named after. It was referred to as the scalenus anticus syndrome in 1927. And subsequently, Dr. Pete coined the term thoracic outlet syndrome in 1956. Now, this is a bit of a controversial entity, and it can be comprised of either vascular or neurogenic forms, or sometimes in some cases mixed forms. So the vast majority of forms of this thoracic outlet syndrome are going to be neurogenic, meaning compression of the nerves, and the minority of vascular outlet thoracic syndromes will be venous and more rare arterial. Now, unfortunately, Adson's famous test actually has quite a low accuracy. It's been shown that in some papers, there is a pulse reduction or obliteration of the amplitude of the radial pulse during this exam maneuver in up to 50% of asymptomatic volunteers. So other tests such as this abduction external rotation test, referred to colloquially as the stick 'em up test, popularized by Roos, for which Roos bands are named after, has been suggested as an adjunct for determining the presence of thoracic outlet syndrome. And this has been refined with the upper limb tension test of Elvey, shown here, where various provocative maneuvers are performed to create stretching of the brachial plexus and induced neurogenic thoracic outlet syndrome. Now, when assessing thoracic outlet syndrome, it's important to note that there is no really one gold standard test. Even clinical evaluation can be problematic. There are certain objective tests that can be performed, whether it's EMG, imaging, or injections. Injections can be comprised of corticosteroid or anesthetic injections into the scalene muscles, or even chemodenervation with botulinum toxin. But it really goes to show how tricky the diagnosis is. And I still feel that most of the diagnosis should be made on clinical grounds rather than any specific imaging test. Now, one of the more important anatomic risk factors is that of a cervical rib. This is going to be the main finding that will be implicated in patients with thoracic outlet syndrome. And sometimes when you're looking at, a chest x-ray or thoracic spine x-ray or even a cervical spine x-ray, it may be difficult to appreciate the presence of these cervical ribs. They may be short or fully formed, and you may be mistaken into seeing a fully formed rib as the first thoracic rib. But one thing that helps you distinguish these two is that the C7 transverse process slopes downward, whereas the T1 transverse process slopes upward. So if you see a rib associated with that downsloping C7 transverse process, then that indeed is a cervical rib. So these ribs, again, they can be rudimentary and small, but they can be large and fully formed. But it's important to recognize that even these small ribs can be associated with thoracic outlet syndrome, and they may be associated with these fibrous bands, again referred to as Roos bands, that can impinge upon the brachial plexus elements. Here's an example of a patient with a cervical rib that actually formed a pseudoarthrosis with the first thoracic rib. And on the sagittal images, you can see how this pseudoarthrosis results in upward kinking of the brachial plexus as it has to kind of travel up and over that pseudoarthrosis. Whereas on the contralateral side, this patient didn't have a cervical rib and a normal course of the brachial plexus nerves. Now, these fibrous bands, again referred to in the literature as Roos bands. Roos originally, in his paper in the 1970s, described 7 different subtypes. And here's an example of what one Roos band could look like. But it's important to note that much like fibrous bands in the quadrilateral space, these are notoriously difficult to see on imaging and are often encountered at surgical exploration. So really, I don't think imaging plays a major role in diagnosing these, but does play a role in assessing for the presence or absence of cervical ribs. Again, those cervical ribs can be associated with these Roos bands. Now, as far as vascular narrowing goes, the most common location will be in that costoclavicular space, less commonly in the retropectoral space. This is where vascular imaging may come in handy, whether it's with CT, angiography, or venography, or what I prefer is post-gadolinium MR imaging. The gadolinium stays around long enough so that you can do both venous and arterial imaging with provocative maneuvers. Here again, just example of patient with their arms down and their arms up. You can see that there's a little bit of functional narrowing of the subclavian vein on the right compared to the left side. And you can often do these with head turning to the left or right, as these may elicit the patient's symptoms as well. Here's an example of a baseball player who had symptoms of neurogenic thoracic outlet syndrome. And you can see, compared to the arms down, to the arms up, that there is narrowing of the subclavian veins bilaterally, although there's not good data or literature out there that indicates to what degree is narrowing pathologic. I've certainly seen a lot of studies, and even if you just look at your CT chest exams, right, patients done with contrast, their arms are up so that they don't obscure evaluation of the lungs and mediastinal structures. And you'll often observe that patients narrow their subclavian veins bilaterally as a physiologic response to the position. So there's no good normative data as to how much narrowing is too much. Some suggest that more than 50% narrowing could be associated with thoracic outlet syndrome. And here's just an example of a patient who developed venous thoracic outlet syndrome. Some of you may know it by its other term, which is Paget-Schroeder disease or effort-induced thrombosis. Now you can see on this conventional venogram that this patient has clot right underneath that clavicle. So in that costoclavicular space, they presented with acute arm swelling. And this patient went on to first rib resection. Actually, they had bilateral rib resections for venous thoracic outlet syndrome. Here's just another example of a patient who presented with acute arm swelling. They actually weren't very active and just woke up with a swollen arm. And you can see the catheter-directed venography showing occlusion of the subclavian vein at the level of the axilla. And following thrombolysis, there's some partial recannulization, although there's some residual clot burden here. And interestingly enough, this patient also underwent a CT angiogram, and you can see with the arm elevated that there's a focal occlusion of that subclavian artery. Actually, this patient didn't have any arterial symptoms. That is, there was no symptoms of distal emboli or ischemic changes. This was just a finding that we happened to see that was positional on CT angiography. Sometimes you can have compression of the brachial plexus by a visible lesion. These can be neoplastic or non-neoplastic. Here's an example of a patient with a very large venous varix that was impinging on the brachial plexus. Here's just an example of a relatively straightforward peripheral nerve sheath tumor. You can see the telltale signs of this schwannoma, including the tail sign, meaning that we have a nerve exiting the mass. We have the split fat sign. We have fat surrounding the nerve sheath tumor because, as you remember, nerves travel within intermuscular planes, so there's often fat around those nerves. And so this is a classic case of a peripheral nerve sheath tumor, or in this case, more specifically, a schwannoma. Here's a patient with neurofibromatosis type 1. You can see the presence of cutaneous neurofibromas and this large mass here. We certainly have to be worried about a malignant peripheral nerve sheath tumor in this case, or malignant degeneration of a neurofibroma. Here's an example of infection of the brachial plexus. Probably don't see scrofula too often, but as you remember, scrofula is tuberculous adenitis. This person actually didn't really have much in the way of adenopathy, but you can see this multispatial infection involving various components of the brachial plexus. You can see wound tracts extending from the base of the neck, extending out towards the axilla, and also involving other parts of the shoulder. And so these are the various wounds that were seen around this patient's neck and axilla. Certainly other mass lesions may be encountered extrinsic to the brachial plexus. A patient with extensive lymphadenopathy from metastatic thyroid carcinoma, I believe this was papillary thyroid carcinoma, which tends to involve the regional lymph nodes. So certainly these can press upon the brachial plexus. And remember, there's a lot of lymph nodes in this area, normally that we can't really see, but when they are involved, for instance, in this case of lymphoma, again, this can result in pathologic compression of the brachial plexus. Other mass lesions we may encounter are those of these Pancoast tumors or superior sulcus tumors, bronchogenic carcinomas affecting the lung apices. And depending on their location, they can affect the brachial plexus and impact their treatment and resectability. Now, superior sulcus tumors can affect the adjacent stellate ganglion, which lives at the cervical-thoracic junction. And this stellate ganglion is part of the sympathetic chain. And when involved, it can result in the Horner syndrome. As you remember, it is the second-order neuron that is affected in Horner syndrome, which is classically characterized by meiosis, ptosis, and anhydrosis. So it's important when you see these superior sulcus tumors to be aware of their close proximity to the sympathetic chain. So right in front of that cervical-thoracic junction, in front of those transverse processes is where you'll find that stellate ganglion. So here's an example of stellate ganglion involvement by a Pancoast tumor. You can see the tissue planes around that cervical-thoracic junction are effaced compared to the other side in this patient who had a left-sided Horner syndrome. Here's an example of an unfortunate patient who was being followed for a proximal humerus fracture, and the astute radiologist noticed that there was some apical pleural thickening, which consequently resulted in additional imaging, a chest CT, where you can see this asymmetric thickening compared to the right side, where the fat plane is completely obliterated. And then finally, the PET scan, which shows this hypermetabolic mass of the lung apex. So brachial plexus imaging can be helpful to surgically stage these patients. And here's a list of things that can result in inoperability of these tumors. So most important is the brachial plexus if it's involved above T1, where you have ingrowth of the C8 or higher level nerve roots. So here's an example of one that extends right up to the undersurface of the rib, certainly obliterating the T1 nerve foramen. But you can see that above it, the C8 nerve root actually has a relatively preserved fat plane, so this could be potentially resectable in this case. Here's another example of an unresectable case, this one involving more than half of the width of the vertebral body. So if it meets that criteria, then this is unresectable. If it's less than half, then it could be resectable. Here's another one that's inoperable. You can actually see it goes above the level of the C8 nerve root, so therefore unresectable. So certainly imaging can be helpful for resectable lesions. Again, if it doesn't extend beyond T1 or involve the C8 nerve root, it could be potentially resectable. Less than half of the vertebral body width, certainly rib invasion is still resectable, and a whole host of other conditions may be met and could be considered resectable in those cases. Here's an example of an unresectable lesion, fluid-sensitive sequence. You can see that this tumor is basically encircling the subclavian artery and goes above the T1 level. So here's the first rib on the other side. You can see that there's tumor infiltration above that T1 level, making this unresectable. And here's just the corresponding chest CT, just the zoomed in image showing the encasement of the subclavian artery by this mass, extending above the first rib and T1, indicating that this is an inoperable tumor. And this is the contrast-enhanced dynamic MRA, just showing nicely the vascular narrowing of that subclavian artery related to the tumor itself. Now you may see diffuse nerve involvement in a variety of entities. Commonly we'll see this as a result of post-radiation changes in patients who've received breast irradiation for breast cancer. But more rarely you may see this as a result of inflammatory, infectious, or hereditary lesions. The hereditary lesions generally are pretty rare. This is just an example from the literature of a patient with Charcot-Marie tooth or hereditary sensorimotor polyneuropathy. Here's just an example of a patient with chronic inflammatory demyelinating polyneuropathy or CIDP. This person actually had a variant of CIDP where there was more unilateral involvement. You can see the thickening diffusely of the left brachial plexus compared to the right. Usually in CIDP, this is going to result in diffuse symmetric thickening of those nerves. Here's just an example of post-radiation therapy. This patient has a history of breast cancer. You can see the asymmetric thickening and hyperintensity of the affected nerves compared to the contralateral side. And just another case from the literature of Charcot-Marie tooth. Now, radiation plexitis typically occurs 1 to 4 years after radiation therapy. Again, this is often seen following breast cancer therapy. The mechanism of injury is thought to be related to direct radiation damage to the nerves, which results in perineural fibrosis. And usually on MRI, what we try to look for is diffuse uniform thickening of the affected nerves, intermediate to bright on T2 weighted images, and really should show no or minimal enhancement. If we start to see nodular thickening or nodular enhancement, then we must start to think about tumor involvement of the nerves, particularly in patients with breast cancer. So one of the key features for differentiating radiation neuritis versus tumors, again, looking for diffuse thickening and hyperintensity of the nerves as opposed to more nodular thickening seen with tumor. Important to understand the normal morphologic appearance, particularly of the cords. Normally these are going to be smaller than the adjacent subclavian artery. So again, here's our stack of cannonballs, the lateral posterior medial cord of the terminal brachial plexus, and you can see that not only are these hyperintense, but they're slightly larger than the adjacent subclavian artery. So the thought initially in this case that this was a case of radiation plexitis, as you look more peripherally, you can see that there are tumor implants within the chest wall in this patient with breast cancer. So that sort of confounded the issue. As we look at the coronal images, again, we can see kind of this diffuse hyperintensity of the right brachial plexus nerves compared to the left side. So certainly this could be a good case for radiation plexitis. Unfortunately, we can see again these tumor deposits along the chest wall. So this one was a little bit of a tricky case and didn't have a clear answer. Here's another case of a patient with metastatic breast cancer. Certainly you can see all the soft tissue infiltration of the axilla. Certainly we can see a metastatic lesion within the proximal humerus. And on the T2 weighted image, we can see all this bulky tumor involvement of the axilla and the terminal portions of the brachial plexus. So this is kind of a no-brainer in terms of tumor involvement of the brachial plexus. So certainly when we look for tumor involvement, we want to look for focal soft tissue masses. These may be low signal intensity on T1, variable on T2 weighted images. Here's the corresponding post-contrast sequence where we can see discrete areas of nodular enhancement around the brachial plexus. So these represent tumor deposits. But when metastatic disease is infiltrative and there's a background of radiation neuritis, it can be difficult to distinguish them from each other. So here's that patient we saw earlier where we weren't sure if we were dealing with radiation plexitis or tumor involvement. And you can see that there's kind of this diffuse infiltration of the nerves with thickening compared to the contralateral side. But as you look through this image stack, you can see that there are some enlarged lymph nodes. And certainly once you give gadolinium, you can see that there's all these nodular enhancing foci around the brachial plexus. So this represented tumor involvement. And what this arrow is actually pointing to is that there's an enhancing focus in the area of the stellate ganglion. So this actually represented a tumor involvement of the stellate ganglion as well. So this is where contrast can be kind of helpful in distinguishing the two. Here's another difficult case. We see diffuse thickening of the right brachial plexus compared to the left. So is this post-radiation neuritis or tumor involvement of the brachial plexus? And the post-contrast images do show some enhancement of the brachial plexus elements compared to the left. So the presence of enhancement really strongly suggests tumor involvement. And finally, this patient went on a PET CT where we can see a lot of FDG avidity. So this was confirmed to be metastatic disease. The last topic that we'll discuss is idiopathic brachial neuritis, or referred to as Parsonage-Turner syndrome. This is a diagnosis of exclusion. This often presents as acute onset of intense pain followed by weakness. You can see in this example of a patient with idiopathic brachial neuritis, you can see the asymmetric thickening of the left brachial plexus compared to the right. This actual patient also had involvement of the suprascapular nerve. Again, you can identify the cords here in the affected portion of the brachial plexus, lateral, posterior, medial, all appearing bright, consistent with some form of neuritis or neuropathy. And here's just a chart that can help differentiate between idiopathic brachial neuritis from other common diseases such as cervical spine, stenosis or radiculopathy, and rotator cuff disease, or even more peripheral entrapment neuropathy. But again, one of the hallmarks is that idiopathic brachial neuritis tends to be acute in onset, so that can be helpful in distinguishing from these other syndromes clinically. What does Parsonage-Turner syndrome affect? Well, primarily it tends to affect the suprascapular nerve in 97% of cases. In about half of those cases, the suprascapular nerve is the only nerve to be affected, but in the other half of those cases, another nerve is affected in addition to the suprascapular nerve. What are those other nerves? That can be the axillary nerve as well as the subscapular nerve, affecting the subscapular muscle and the teres major muscle. In most cases, it's unilateral, but in a minority of cases, it can be bilateral. If you see bilateral involvement, you don't necessarily want to discount Parsonage-Turner syndrome. Here's a patient who presented with classic Parsonage-Turner syndrome, presented with acute weakness followed by pain. And this patient actually recovered with a steroid taper. The coronal small field of view images, you can identify the suprascapular nerve as it takes off from that superior trunk of the brachial plexus. And you can see that it's hyperintense compared to the other nerves. As we look more laterally, we can follow the course of the suprascapular nerve towards the suprascapular notch of the scapula, and you can see the accompanying denervation edema of the supraspinatus and infraspinatus muscles. On the sagittal image stack, as we move more peripherally, we can actually identify the individual nerve roots. Remember, identify that first rib. We have T1, C8, C7, 6, and C5. As we move more peripherally, we can see that suprascapular nerve emerging from that upper trunk. As we move more peripherally, we can see it extending towards the suprascapular notch. And of course, again, we can see the denervation changes of those muscles. Here's the large field of view of imaging showing the asymmetry of that suprascapular nerve we can see on this side compared to the other side. As you move more centrally, here you can see that edematous suprascapular nerve on the left compared to the right, where you can actually hardly see that nerve. There's the nerve on the right, and there it is on the left. So having large field of view coronal imaging can help you look for subtle side-to-side differences. Of course, idiopathic brachial neuritis is a diagnosis of exclusion, so you want to rule out more common causes. This is a patient with spinal stenosis. You can see multiple levels of disc bulging and spinal canal narrowing. This patient also had neuroforaminal narrowing. You can see indeed that this patient does have some denervation changes in some of the rotator cuff muscles. We have both involvement of suprascapular and axillary nerve distributions. And this patient's shoulder symptoms actually resolved after spinal decompression. So common things being common, be on the lookout for cervical spine pathology as a cause for peripheral weakness and pain. Here's an example of a patient who might have Parsonage-Turner syndrome. You can see that there is denervation edema throughout the shoulder, but in this case, this patient had an intracranial hemorrhage at the level of the left middle cerebellar peduncle. So you always want to be wary of more central causes of denervation. Here's an example of a patient with a C5, C6 herniated disc. Again, we can see denervation changes about the shoulder girdle muscles, including suprascapular and axillary nerve distributions involving the supraspinatus, infraspinatus, as well as deltoid muscles. So I know that getting all these nerve distributions and their respective muscle innervations can be difficult to keep straight in your head. So often referring to some sort of chart or just looking it up on the internet can be helpful when you're trying to look through these cases and try to really pin down if you're dealing with a nerve root lesion, a peripheral nerve, or something more central. So with that, that concludes our discussion of the brachial plexus. Really would like to give special thanks to Dr. Pathria with her contributions to this talk, as well as her contributions to building up our brachial plexus imaging practice. Really like to thank you again for your attention, and I'll see you the next time around.